All right, welcome everyone. So we're going to talk a little bit about antibiotics today. I do some educational material review disclosures. We're going to talk about the different classes, applications, some holes in coverage and side effects, toxicities of different antibiotics. And I think everyone in Zoom could probably be included in this. We'll just hold your cards for you, but there will be some yellow boxes throughout the lecture, and if someone can guess or attempt to figure out what's under there, I have $10 Starbucks gift cards to hand out. So these are just kind of a broad overview of different antibiotic classes and their mechanism. Does anyone know what affects DNA gyrase or topoisomerase? You might be able to deduce this by seeing this is a major class of antibiotics that we use daily. Any guesses?
The tetracyclines.
No, that's a good guess though. Fluoroquinolones, all right, Sherry, for the win. All right, so yeah, we'll talk a little bit more about each of these, but this is just kind of broad overview. So, all right, so the beta-lactams, this is a cell wall active agents. Includes penicillin, cephalosporins, carbapenems, and aztreonam, kind of. It's a little bit different than the rest, but most sources include this. So these all bind to penicillin binding proteins and block transpeptidase, which is important for cross-linking of the cell wall. And it affects rapidly dividing bacteria the most. So in the growth phase, if bacteria are stagnant and not reproducing, it doesn't really, or not replicating, it doesn't affect them as much. So sometimes if you mix penicillins with bacteriostatic medications, these will work less well. Bacteria are smart. They develop mechanisms to avoid being killed, so they develop beta-lactamases, which essentially attacks and cuts this beta-lactam ring. So then we in turn develop these beta-lactamase inhibitors, which is included in a lot of the newer drugs. And as a class, these typically have poor oral bioavailability, but they're not concentration dependent, they're time dependent killing, so you don't really need to meet high concentrations. So the poor oral bioavailability is not super relevant most of the time. Maybe in CNS infections and endocarditis it is, but for other routine infections, it doesn't really matter. So penicillins, half-life is short, they're renally cleared, and you have to adjust the dose for renal dosing. There are a couple of penicillins that do not require renal adjustment. This is not just for penicillins, but beta-lactams. Does anyone know any of the beta-lactams that don't have to be adjusted for the kidney? One we use every day.
Ceftriaxone?
Ceftriaxone is one, yeah, and then nafcillin is the other one. These medicines are highly protein bound for the most part. They act as haptens, and this plays a role with their development of hypersensitivity reactions. Now the antigen is typically either the side chain. If we look here, there's these side chains which are attached to the beta-lactam ring. So that's in this light blue with the R here, that they're all quite different. Or the beta-lactam ring itself. So if something is affecting the beta-lactam ring, it's typically an allergy that will cross to other drugs. If it's a side chain dependent hypersensitivity, it will be specific to that antibiotic. So the penicillins, there's several different generations of penicillins. The first generation is just Pen-G or Pen-VK. These typically are used for enterococcal infections and strep infections. They also affect the spirochetes. The next generation is the anti-staphylococcal penicillins, which are penicillinase resistant, and this is really, it's nafcillin is the only one we use. And then they've kind of developed these broader spectrum penicillins, which is ampicillin, amoxicillin, and eventually piperacillin. Now, the spectrum of the broader spectrum penicillins, there's this mnemonic helps. And we typically add this to patients who have ampicillin to meningitis and patients who are over 50 or immunocompromised. So, yeah, so think about it as like the tails of life, early life, late life, and then anyone who is kind of immunologically at the kind of immature stage through immunosuppression. And then, Zosyn, of course, has broader the Enterobacteriaceae kind of activity with Pseudomonas included. I'm going to run through these slides pretty quickly because we don't need to kind of go through this ad nauseum, but these are the different classes of or generations of the cephalosporins, kind of similar to the penicillin generations. The one thing I would say about the first generation is cefadroxil is really fallen into favor in the last few years because it's better than Keflex because the dosing. Keflex was always 4 times a day. It's hard to get anyone to take anything 4 times a day. Cefadroxil you can oftentimes use once a day, but for like hospital discharge type of infections, if the infection was severe enough to require hospitalization, we're usually giving it BID. Now the first generation of cephalosporins, does anyone know if they're able to be used for meningitis or not, or central nervous system infections? So if that was the initial thought, is that we couldn't use them. There were some really poor studies done back in the 60s, and it just became kind of folklore that we couldn't use them. In the last few years, some studies have come out showed better penetration. This really only comes into play with MSSA and endocarditis with kind of embolic phenomenon to the brain. So we will use cefazolin in that situation. Ceftriaxone, of course, we use for meningitis as well, pneumonia. It has expanded gram-negative coverage when compared to the first generation cephalosporins, and ceftazidime is even a little bit expanded more than ceftriaxone, which includes Pseudomonas coverage. Ceftaz, its niche is really in dialysis patients because you can dose it with dialysis, whereas the other cephalosporins and most of the penicillins require more frequent dosing. Cefepime, again, Pseudomonas, also has AMP-C activity. And then the newer cephalosporins, I'm not going to talk a lot about these. I want this lecture to be a little bit more about practical knowledge, but ceftaroline is ceftriaxone plus MRSA coverage. Cefiderocol is used for carbapenem-resistant infections. And then Zerbaxa, you should really be thinking about kind of difficult to treat resistant Pseudomonas, and Abacaz is again for carbapenem-resistant infections. The only thing I'll say about carbapenems, ertapenem, the reason why we don't use it inpatient, it's highly protein bound. Patients with hypoalbuminemia will, they won't have adequate concentrations because the drug gets cleared if it's not actively protein bound. So if your protein is low, your urine is going to clear the medicine. Also, in critically ill patients, oftentimes your renal clearance goes up. So anyways, you avoid ertapenem in acutely ill patients, and that's why we usually reserve it for discharge. And also, the ertapenem lacks Pseudomonas activity, which is important to know. So this is kind of a complicated slide, but I just want to point out a couple of things. Cefazolin, if you look at it, it has no cross-reactivity with any of the other beta-lactams. So if someone has an allergy to any of the beta-lactams, but not specifically cefazolin, you can still use cefazolin. And this is something that our infectious disease division is starting to rely more heavily on. It's made it into our protocols formally through the institution, which I'll talk a little bit about later. But it's good to know that there's no cross-reactivity. Now, the Early generation cephalosporins, the cefadroxil, cephalexins, they more or less cross-react with the penicillins. So the old school typical penicillins and the broader penicillins, but they kind of fall into an allergic category with the penicillins, whereas the later generation cephalosporins, the ceftriaxones and cefapemes, they don't have any cross-reactivity with the penicillin drugs, but they do cross-react with the other cephalosporins. So if someone has they say they're allergic to penicillin, it really shouldn't preclude your use of all beta-lactams. Now, if someone has, angioedema or anaphylactic reaction and there's other options, it's probably safe to just avoid it. But if push come to shove, it's reasonable to use. And we have Stephanie, who's our antibiotic ID nurse practitioner, and she'll come around and test. I don't know if y'all have been utilizing her at all, but that's something that we do in the daytime much more frequently. So this is the perioperative antibiotic allergy algorithm, UAB's protocol. And you see if someone has an allergic reaction to any penicillin or cephalosporin, as long as it's not to cefazolin, essentially all these boxes lead to proceed with cefazolin, unless you specifically have a history documented to cefazolin. So they are, as an institution, have kind of endorsed this thought that there is no cross-reactivity, and I feel like that gives us some backing to do the same thing. All right, so now, from the cell wall agents, these are the ribosomal agents. A good portion of our antibiotics that we regularly use fall into this category. The macrolides, azithromycin, linezolid, and the tetracyclines. So the tetracyclines make good intracellular concentration. They impair protein synthesis through the ribosomal. I guess I should say, what does this ribosome do? So this ribosome complex, the 50S and the 30S, it reads the mRNA that is produced. And then these tRNA molecules, which hold on to individual amino acids, then bind into the ribosomal site and kind of follow down the mRNA coding and create a protein. So, they just block protein synthesis. The spectrum for the tetracyclines is broad, atypical infections included, the tick-borne infections, the spirochete infections. We have a limited supply of penicillin now, and we have been using doxycycline for a year or more now for non-tertiary syphilis, so early or even late syphilis, which doesn't have CNS involvement. We just treat with doxycycline now. The bioavailability is good. We use doxycycline all the time, but these patients should not take doxycycline with dairy products or with antacids, and we probably do a lousy job of controlling for that in the hospital, but this can significantly impact absorption as much as 50 to 90% in some patients. So you should separate the intake by at least 2 hours. If they're on a PPI, switching to famotidine or an antihistamine is helpful. Doxycycline in particular causes photosensitivity, so I always counsel patients to wear sunscreen or long clothing. Obviously, it's going to be more important in fair-skinned individuals. And pill esophagitis, I always tell patients to take doxy with a full glass of water and don't lay down for 30 minutes after taking it, because it will cause really bad pill ulcers in the esophagus if it doesn't get down all the way. Minocycline has less photosensitivity. It really carries all of the gram-positive coverage of doxy, but also has a bit broader gram-negative coverage, and we'll use it sometimes in that capacity. Long-term use of minocycline can cause blue-gray skin, people kind of look like a Smurf. So, that's not optimal, and it's not always reversible. So that's something to think about, but, we're not really going to be prescribing it long-term here. Tigasil, omadacycline, I'm not really going to talk much about these. I guess I added an extra slide there, but the Tigasil is typically used for patients with extensive drug allergies and can't use other antibiotics. Patients with pneumonia and sepsis who receive Tigasil typically have increased mortality, so that medication fell out of favor, but it does have that one role for patients who just can't have other medications. And then the omadacycline and eravacycline, these are just newer antibiotics. They really haven't made it into our common usage, but complicated intra-abdominal infections, MRSA, coverage are notable for both of them. The macrolides, azithromycin is really the only one we use. It's excellent for respiratory, germs, long half-life, so single daily dosing, and it can cause QT prolongation and GI upset. We're all very familiar with that. The aminoglycosides, we don't use these much. I'm not going to talk a lot about it, but they do have a special action at the ribosome. They cause what's called the tRNA wobble, so they cause miscoded proteins to be created, which kills cells. If you're creating a bunch of mutated proteins, cells don't do well with that. I think the single role for hospital medicine is the single dose treatment of cystitis in patients with ESBL pathogens. I use it for this regularly when the ER calls me and they say someone needs to be admitted for some extended course of IV antibiotics, and I just discharge people with a single dose of, tobramycin or whatever is sensitive, and that's very helpful. And notably, the toxicity is lower with a single dose. I think everyone except for someone who may be kind of borderline in need of dialysis can benefit from this. I think the risk of hospitalization and IV access for 5 to 7 days outweighs the risk of a single dose of aminoglycoside, so I feel comfortable doing this all the time. Linezolid, this is good for MRSA. It has good bioavailability, but it is bacteriostatic rather than cidal, so we don't want to use it for active bacteremia unless we have to. And it's also one of the drugs of choice for VRE, along with daptomycin. The toxicity of linezolid is really myelosuppression, which is thrombocytopenia or leukopenia. It usually only occurs after 2 weeks. So if we give courses longer than 4 weeks, we're always checking labs every 2 weeks, but up to 4 weeks, I feel comfortable just giving a prescription for linezolid. So if patients have a self-directed discharge for endocarditis, whether it's MSSA or MRSA, I think linezolid is a good option just because it has good oral bioavailability, makes good serum concentration. So I would consider this for treatment of either of those infections. I would give up to 4 weeks. If they had 5 weeks left, I would say you're going to have to follow up with your primary and get the rest of the course. That's kind of on them, but at least they have something to take when they leave. The serotonin syndrome, this has been really debunked. You can let people continue on their SNRIs or SSRIs or anything other than MAOIs, which we really don't see any longer. Maybe if we do a consult in the psychiatric medicine service, there will be patients on MAOIs, but otherwise, there's really no good data that suggests that serotonin syndrome is a legit concern. Clindamycin, oral anaerobes, otherwise it should really be avoided other than this thought of working for toxin production inhibition. So for NECFASH or toxic shock syndrome, use it for the first 3 days, then stop it. Other ribosomal agents, particularly linezolid, also have the same benefit. So if someone has like a vanc allergy and they're being given linezolid, there's no reason to add clindamycin on top of that. That's just something to know. It has horrible GI side effects. It's hard for patients to tolerate. It's multiple times a day dosing. It's just a lousy drug. I prescribed it maybe 3 times in my life. I don't like it, and the ER and surgeons love it, which is irritating. Okay, fluoroquinolones, and then I think we're gonna move on to more fun things. But as we said, gyrase, topoisomerase inhibition, so the DNA can't unwind to do its thing, whether that is make proteins or cellular replication. So the fluoroquinolones impact the unwinding and rewinding of nucleic acid. The 3 main fluoroquinolones, and of course, as everyone knows, we only have 2 here, but Cipro, Levaquin, and Moxi. Levaquin and Moxi are the respiratory fluoroquinolones. There's also a gadafloxacin, which we really don't see any longer, but this mnemonic, get my lungs, gadafloxacin, moxifloxacin, and levaquin, that's kind of the mnemonic for respiratory fluoroquinolones. And you see the spectrum from Cipro, which is most gram-negative active, down through Moxi, which is most gram-positive active. And Cipro and Levaquin both retain pseudomonal coverage, and the pseudomonal coverage is relatively equal. It's not like Cipro is better, but Levaquin has expanded gram-positive coverage, particularly of strep pathogens, which is what makes the respiratory fluoroquinolones is their ability to cover strep, and they also have this atypical coverage, which are commonly seen in community-acquired pneumonia. The one thing about Moxi that you should know, well, there's really 2 things, is one, it doesn't get into urine, so you can never use it for a urine infection. It's not going to work. It's hepatically cleared, so definitely don't want to do that. And then the second thing, Moxi, in contrast to the other fluoroquinolones, has some anaerobic activity, and it can be used for things like aspiration pneumonia or community-acquired intra-abdominal infections. I wouldn't really use it for hospital-acquired intra-abdominal infections because the anaerobic coverage is not excellent, but it does retain some anaerobic activity. Delafloxacin is something we may see more in the future. It was approved several years ago. It is the broadest of all the fluoroquinolones. It has MRSA, pseudomonal, it retains atypical, gram-positive, gram-negative coverage. It really covers everything, and it's used mostly for diabetic foot infections in the outpatient setting. It hasn't been approved by our P&T committee, so we won't see it now, but it's something that you may run into, and I just want you to at least be aware to recognize the name. So the toxicities of fluoroquinolones are many, and for this reason, you don't want to use the fluoroquinolones for kind of minor infections. So a lot of these toxicities are black box warnings. So if someone has a flare of chronic bronchitis, sinusitis, cystitis, and they're not very sick, there are alternatives to use. You should use the alternatives. It's hard to defend your choice of a fluoroquinolone if there's many alternatives and the patient isn't very ill. However, in more severe infections or patients with allergies, the fluoroquinolones are fine to use. Now, tendinopathy is one of the major ones. It affects the Achilles tendon the most common in older patients, patients on corticosteroids, etc. CNS effects, we all know about the seizure, but it can also cause this kind of weird neuropsychiatric effects, lightheadedness, psychosis, and just like it can affect the CNS, it can also affect the peripheral nerves, does similar things, just peripheral neuropathy. Most of the times these are reversible when the drug washes out, but it's something you should think about in patients who are starting fluoroquinolones in the hospital. If they start feeling weird after a day or 2, it's not always clear for them to describe like, something's going on with my head, but encephalopathy, things like that, I should probably think about a change. Sugar, dysglycemia can cause your sugars to go up and down. If someone's like a wildly uncontrolled diabetic, that would be more important. Otherwise, it's really not a major concern. And then there is this, just like it can affect the soft tissues, connective tissues for tendinopathy, there is an observational study that reported increased aortic dissection and AAA rupture after courses of fluoroquinolones. There have been other subsequent studies that haven't shown the same effect, but if someone is kind of vasculopathic, it's something that should be considered. And then anyone have any idea what can affect the oral absorption of the fluoroquinolones? If you guess, you're probably going to be right. No, I'm sorry. I mean, it's going to be the same things over and over. So the tetracyclines, the fluoroquinolones, even the macrolides, it's all antacids, divalent cations, so dairy, calcium, magnesium, iron, these things can affect the absorption. We are almost universally giving fluoroquinolones by mouth. All these ribosomal agents we almost universally give by mouth, so this is important, and I think it's really not looked at enough. So just be aware of that. Macrobid. So it's kind of unclear to me exactly what its mechanism of action is. Anytime you look it up, it'll list like everything in the world. It affects proteins, it affects DNA, it affects the energy cycle of the cells. It does everything. I don't understand that, but I'm going with it. So this drug is highly active against a broad spectrum of gram-negative germs, including ESBL. However, we rely on the kidney to concentrate this medicine, and you have to have a functional kidney. The creatinine clearance is important. Does anyone know the threshold for where we stop prescribing nitrofurantoin? That's the manufacturer's risk. The American Geriatric Society and some other major medical groups that publish guidelines have said greater than 30 is fine. You can have increased toxicity if the creatinine clearance is very low. It's the macrobid is just going to sit around in your body, and it can cause pulmonary fibrosis and peripheral neuropathy, drug-induced liver injury. So if the creatinine clearance is horrible, not only is it not going to work because it's not getting concentrated in the kidney, it's also going to lead to increased toxicity. So it's kind of like a double no-no. And because it doesn't reach adequate concentrations in the serum or in the upper nephron, it's not advisable to use for pyelonephritis or anyone with sepsis. It's just for simple cystitis. Now, just to run through some brief kind of conditions, I'm going to talk the most about pneumonia, but for inpatient MRSA treatment, purulent cellulitis, Vanc is going to be our go-to. Dapto is a fallback. You can use linezolid on discharge, but again, if someone comes in and they're sick with cellulitis, you don't know if they're bacteremic, you don't want to start with linezolid. And then of course we can de-escalate to any of the oral active agents, Bactrim, Doxy, linezolid, minocycline, any of those are fine. If someone has pneumonia, the key is, don't use daptomycin. Vancomycin is okay, linezolid is okay. Sometimes we'll use ceftaroline. For bacteremia, for uncomplicated bacteremia, vancomycin is our go-to. For complicated bacteremia, there's not really a good definition of what is complicated. I'll tell you what I think complicated bacteremia is. If it's high grade, meaning if they have 4 out of 4 bottles that are positive, or they've had persistent bacteremia on multiple days, if they have multifocal infection, or if there's an intravascular nidus. So you see like endocarditis that has embolic phenomenon, splenic abscess or anything like that, CNS abscess. Those patients really would benefit from synergistic therapy with dapto and ceftaroline, and I think we should all, as hospital providers, be comfortable initiating that without ID. There's nothing special about these drugs that is particularly toxic or concerning. And particularly at night, I think it's totally fine, or late in the day when you know ID is not going to come by until the next day. The patient would probably be better off as far as earlier clearance of bacteremia and likely improved mortality if we just go ahead and switch to synergistic therapy. ID has an extremely low threshold to do this now, and it's kind of like slowly over the last 5 years becoming thought about even as like the standard of care in these kind of more aggressive bacteremias. If you accidentally switch someone to daptoceftaroline with an uncomplicated bacteremia, it's going to do nothing bad to them. So I would err on the side of switching to synergistic therapy if you're kind of on the fence. And then we continue this synergistic therapy until blood cultures are cleared, and then maybe 3 to 5 days later, and then we'll typically drop one of these agents. It's most commonly ceftaroline that we drop, and we continue dapto. If someone has a bad pneumonia as a component of their infection, we don't want to drop to dapto alone, so we'll oftentimes just switch to vancomycin monotherapy. But daptomycin will, even though it doesn't cover pneumonia, it will cover embolic phenomenon to the lungs. So if someone has, right-sided endocarditis with embolic disease that is throughout the lungs, but no parenchymal consolidation, the dapto is fine. But I think it's reasonable not to push that theory. If you're worried about pneumonia at all, I would probably at least have ceftaroline on board with the dapto to cover the pneumonia aspect. Ceftaroline resistance is not tested at our institution unless it's requested, but I think there's only been like one incidence of ceftaroline resistance since we've had this drug, so it's exceedingly uncommon. If I switch someone to daptoceftaroline, I'm only testing them for ceftaroline resistance if they've had persistent bacteremia after the switch for another 2 or 3 days. Then I'll go ahead and send the test, but I don't routinely test for ceftaroline because the coverage is so reliable. And then after bacteremia, which I already touched on this, step-down therapy is, I think, optimal with linezolid. If you can't use linezolid for whatever reason, maybe they have bad thrombocytopenia at baseline, you'd probably be using something like Bactrim or Doxy with rifampin, but that someone from ID will be on board if that becomes the case. And then these long-acting glycopeptides, Dalvance is really the main drug that we use here. There's 2 different formulations, one with 1125 milligrams and one with 1500 milligrams. The 1125 milligram dose has therapeutic levels that last for about a week, whereas the 1500 milligram dose, the therapeutic levels last for 2 weeks. This is most commonly used in patients with substance use disorder they just get itchy to leave the hospital. So we can oftentimes do 2 to 4 weeks of inpatient antibiotics and then give them 1 dose and have them come back 2 weeks later for a second dose, or give them 1 dose at that 4-week mark and they're done. So it's very helpful. Sometimes patients will come in to the ER with some crazy story about how vancomycin is the only thing that helps them. And, our antimicrobial stewardship team doesn't like to use Dalvance unless there's documented MRSA on culture. But given how overcrowded we are, I have recently, in few situations, one happened just 2 days ago when the ER called me about using Dalvance just to get someone out of the hospital. I don't want someone sitting here for 5 days taking up a bed when they're very mildly ill and they're just kind of have a CNS disorder thing and they need vancomycin. So I just give it to them and get them out of here. And I think that's not unreasonable. Outpatient treatment of CAP, I'm going to focus more on inpatient, but the strongest recommendation is for amoxicillin in otherwise healthy patients. Azithro, Doxy are kind of second line agents. If they have comorbidities, they want dual therapy with augmentin and azithro or a respiratory fluoroquinolone. And then inpatient, there's two different things you have to think about with inpatient treatment of community-acquired pneumonia. And remember, this criteria of healthcare associated pneumonia is no longer. So anyone who's coming in really from the community, it doesn't matter if they spend most of their life in the hospital, they develop the pneumonia out of the hospital, this is a community-acquired pneumonia now. So think about how severe the pneumonia is. And the major criteria are really ICU criteria, septic shock, ventilator. They're really not going to affect us in hospital medicine on the floor. But the minor criteria, and it's essentially just anyone with severe sepsis. I mean, you can look at this list of things, but it boils down to someone who's really sick, physiologic derangements, they have severe pneumonia. And then the second thing to consider is what is their risk and history of MRSA and Pseudomonas. So have they had MRSA or Pseudomonas cultured from the respiratory tract in the last year? That's the most important risk factor, just like the most important predictor of future suicidality is past suicidality, as is MRSA and Pseudomonal pneumonia. And then the second criteria is if someone's been hospitalized, which exposes people to hospital-acquired germs, and if they've received IV antibiotics, there's more likelihood of having drug resistance, et cetera, if they're recently exposed to IV antibiotics. Now, this is the IDSA guidelines, which is kind of stamped and approved by the American Thoracic Society as well. They specifically list parenteral antibiotics. It's not just someone had a course of oral azithromycin. So I just want to make that clear. So for inpatient treatment of pneumonia, the typical coverage is first line is Unison or ceftriaxone coupled with azithromycin or a respiratory fluoroquinolone. And then second line is Unison or ceftriaxone with, what would you guys use as second option? You guys are making this too hard. It's just doxycycline. So now we only use this really if someone has a prolonged QT. Otherwise, I mean, I guess maybe some allergy stuff. I don't commonly see major allergies to azithromycin, but I suppose it can happen. I mean, then for extended coverage, we're just covering MRSA and Pseudomonas. So I've kind of boiled the guidelines down to this slide. This, I think, is the most important slide about the pneumonia coverage. So if someone does not have MRSA or Pseudomonas risk factors, it doesn't matter if it's severe pneumonia or non-severe pneumonia, they get typical coverage. They don't need vancomycin, they don't need cefepime, they just get typical antibiotic coverage. Now, if they have severe pneumonia, you will do the MRSA nasal swab, and if that test is positive, you could consider broadening, but routinely, you do not need to start with vancomycin. So when the patients come in with severe disease, but no risk factors from the ER, you should feel comfortable and supported by guidelines by de-escalating. Now, if patients have recent hospitalization or IV antibiotic exposure in the last 90 days, if they're not that sick, they get typical antibiotic coverage. If they are very sick, then you add empiric MRSA and pseudomonal coverage. And then if someone's coming in with community pneumonia and they have a history of either MRSA or Pseudomonas on culture within the last year, whether they're very sick or even mildly sick, they should have their coverage extended to whichever germ they had isolated in the past. And sometimes if I'm not like a strong believer that this is a pneumonia, or their previous cultures are kind of, I'm skeptical about them. I won't always start them with expanded coverage, but you should collect blood, sputum cultures on these patients, the MRSA nasal swab, etc. And if those cultures are negative, we should be de-escalating back to typical coverage. So the guidelines emphasize de-escalation to typical coverage if cultures are negative, and this I think is the most important slide. We should all kind of have this memorized more or less. A couple other things I'll talk about, and then I'll stop and take any questions, but just resistant gram-negative germs, AMP-C, this is a beta-lactamase that's amplified by exposure to ceftriaxone. Really, any of the penicillins or early generation cephalosporins can induce AMP-C production. So that includes Zosyn, ceftazidime, ceftriaxone, of course, ampicillin, all of them. The only thing that doesn't seem to induce it strongly and furthermore is resistant to it is cefepime. So these three germs, the Enterobacter, the Klebsiella aerogenes, and Citrobacter fundii, if you see either of these germs on culture, they should never be treated with anything other than cefepime or above. You go from cefepime up to the carbapenems, or you can go to other classes outside of the beta-lactams like Bactrim or fluoroquinolones if it's a urinary infection, of course, macrobid. But we should at least have some cursory knowledge of what this AMP-C means. Now you will see on the Enterobacter antibiogram or susceptibility panel, you won't see Zosyn listed there, and that's because they don't want us to use Zosyn. So sometimes when they suppress, and I know it's a strange world that the microbiologists live in, they suppress some antibiotics because they expect you to know that if Ancef is sensitive, then ceftriaxone will be sensitive, and then other times they suppress antibiotics because they don't want you to use the medicine. So anyways, it's hard to interpret. We've been working with micro for years to try to make it more intuitive, but anyways, these three germs, you should know that anything other than cefepime is really no good within the beta-lactam family, not including the carbapenems, of course. All right, ESBL, again, the treatments of choice are just avoid the beta-lactams if you can. Macrobid, Bactrim can be used for cystitis. Oftentimes, ESBL germs don't just carry the extended spectrum beta-lactamase, they carry multiple resistance mechanisms. So sometimes you'll see they're just resistant to everything. And that's kind of where that aminoglycoside, single dose aminoglycoside can come in helpful. For pyelonephritis, again, Bactrim, fluoroquinolones, if they're very ill and you're worried about bacteremia, carbapenems, any ESBL bacteremia, whether it's sensitive to Bactrim or fluoroquinolone, they should be initially treated with a carbapenem, and at our institution it's meropenem because there's mortality benefit to that. And then after they defervesce, you can step down to Bactrim or fluoroquinolone, but all of the ESBL bloodstream infections are meropenem up front. And then, this is just kind of for everyone to know a little bit about. The carbapenemases are becoming more and more common. KPC is the most common in the US, and then these metallobeta-lactamases are becoming more common. again, the treatment, if you can avoid the beta-lactams, that's optimal. And if you can't avoid the beta-lactams, then we're gonna start using these newer generation beta-lactam, beta-lactamase inhibitors like Avacaz or cefiderocol now we're using more frequently. So that's really all I'll say about that. So in closing, just to make a couple of kind of sweeping statements that haven't been touched on, for serious MSSA infections, you want to have these patients on cefazolin or nafcillin. Oftentimes, if someone has a serious MSSA infection and some urinary tract infection that's not associated with the MSSA, we'll put them on cefazolin and ceftriaxone, or cefazolin, like whatever. We'll use 2 beta-lactams if we have to, because using ceftriaxone or cefepime or Zosyn for MSSA bloodstream infection is no good. Even though those antibiotics have MSSA activity, they don't cover them as well as cefazolin or nafcillin. Clinda and aztreonam are typically useless. Zosyn, Unison, and the carbapenems all have good anaerobic activity. You don't need flagyl if you're using them. And then always think about doxycycline if someone's septic in the summertime and they're not responding. Tick-borne, atypical stuff is something that should be considered. I don't think anyone should die of sepsis in the summer without doxy. The last thing I'll say is that this antimicrobial stewardship link, so if you go to, on the one main page, you go to groups and then click the antimicrobial stewardship link, there are antibiograms and guidelines, these treatment guidelines for C. diff, pneumonia, UTIs, cellulitis, all kinds of things. These can be very helpful. I don't know if everyone's aware of them, but they're being created more and more over the last couple of years. The antibiogram is very helpful. I look at this probably every time I'm at work. You should use this to guide your therapy. You don't have to remember which antibiotics cover what if you just look at this chart. So I just wanted to include it in this so that, if you get the PowerPoint, at least it's on there. And then lastly, I just created this diagram. It's kind of shows what antibiotics cover what. If something's boxed in yellow, it's kind of treatment of choice. But that's all I have. If anyone has any questions, I'm happy to answer them.
One question, they were just asking if you can send me your slides and also.
Yeah, absolutely. I've already emailed them to you, actually.
Oh, you did?
Mm-hmm. Okay, well, whoever answered a question, right, there's gift cards here. Kim, go ahead.
No, it was me. What do you see that we do wrong the most, our service?
Oh, I don't think that APPs do things wrong more than anyone else. I just think people should feel empowered not to reflexively start antibiotics all the time. I think that's the biggest, just kind of knee-jerk reflex. Oh, someone is tachycardic, someone has a low-grade temperature, someone's white count goes up one day. Like, it's okay to watch them. I mean, look, if they're very, very sick, that's different. But if someone's otherwise well, I think it's reasonable to watch, see if someone declares themselves. There's 1,000 things that cause fevers in the hospital that are not infection. And oftentimes, and really more often than not, someone, if you just watch them and they have just a low-grade temperature or white, the next day it's going to come down. If you started antibiotics, you would think that is the reason why, and you would be committing them to a course. So, but I don't think the APPs do anything more wrong than the physicians. I mean, everyone's an equal offender. Yes, Jana.
We have a question from the chat.
Okay.
Is there anything special to know about Vitodra? I think a patient was admitted recently coming in to get that specifically.
No, I mean, it's a question from the chat. I feel like a YouTuber. No, I don't think so. I mean, it's just used for expanded spectrum gram-negative activity. No, I mean, those drugs are sometimes required just because of spectrum, but yeah, I'm not sure what they're getting at with that, but I don't think that we need to know anything in particular about it.
We have another question.
Okay.
For listeria meningitis, is it appropriate to use ampicillin?
Yes, and I would say this, like, it's easy to say, well, 50 years old, strict cutoff, all this. If someone comes in and they're 48, 47, and they're very sick, and you think they have meningitis, now we don't see meningitis that often, but when you see it, it's not subtle. It's not like, oh, is your neck stiff? No, it's like they're like, prostrate and not moving and encephalopathic. It's like these are like legit illnesses. I would favor erring on the side of ampicillin. Just in an ID conference last week, they presented a case of someone who was younger than 50, but immunocompromised, had horrible listeria meningitis with CNS abscesses and everything. And the diagnosis is very challenging to make. So it's not like you can rest on cultures. Now we do have the BioFire, so anyone who has concern for meningitis, if we're doing LPs, you should be sending the BioFire. It does include listeria, and that increases our ability to diagnose listeria. But I would absolutely add listeria, have a low threshold to do that. In those patients, it could be the difference between life or death. I know it sounds stupid, but it really could be. And also for meningitis, remember that initiation of corticosteroids early in the course is important. So when you're ordering antibiotics, also start dexamethasone. I think it's, it's 6 to 10 milligrams Q6 for 4 days, and it will reduce morbidity, reduce incidence of deafness, of neurologic complications. So, remember that as well. Anything else?
I have a question.
Yep.
We have lots of people that we see come in often, especially some of like our suprapubic catheter type people who come in with these kind of chronic infections. What is the best way to tell? Because they may present and look kind of sick on paper, but as far as being colonized, like what are some of the best guidance?
Well, I tell everyone that works with me knows, like, I don't want to hear about how stinky your urine is. I don't care about how stinky your urine is. All urine is stinky. It's just, that's urine. It's like, I don't want to hear about my poop smells like so different. I don't want to hear about it. It's all stinky. So also in suprapubic cas, you will get proteinous secretions in the catheter all the time. So it like looks purulent. I don't really care about that so much. Now I care about that a little bit more than I care about the stinky urine. But what I really care about is someone symptomatic. Are we ordering a urine culture or urine analysis just because they're coming into the hospital for some other reason? Because if that's the case, I'm just gonna ignore it. I don't care what it grows. If someone tells me they're, I feel, and oftentimes people with suprapubics are paraplegic or whatever. So if they tell me like, it's hard for me to describe, but I feel like I felt when I've had other urinary infections, I will hold some weight to that. Now, some people are crazy and will just say that, but you have to just kind of use your gestalt to kind of hash that out. But, are they having fevers? Are they having lower abdominal pain, nausea? Are they feeling like they do when they normally have infections? Those are things I think about. Because the UA is really not going to be helpful. It's always going to look crappy. So, the ER, it gets super excited about it. And that's in one of those situations where it's okay to not treat them right away. Like, it's okay if someone has, 15 white cells on the urinalysis and they're coming in for heart failure exacerbation. They don't have to get ceftriaxone. Like, it's okay for us to get a culture and just kind of see what happens. That's fine. So I hope that answers your question.
I do a lot of consults with ortho, and there's one particular surgeon that loves urine cultures, just they'll pop out of nowhere.
Yeah.
If they're growing bugs in like high colony forming units but still asymptomatic, are we still ignoring those?
Absolutely.
Okay, thank you.
100%. Yeah. I always ignore, I shouldn't always, but 99.9% of the time you're ignoring candida in the urine as well. Some of the surgeons get excited and add fluconazole. That's really never necessary. Exchanging a urinary catheter if someone has candida is reasonable, but beyond that you don't need to do anything. But yeah, oftentimes people will call me or talk with me and they'll be like, well, but it's growing. And it's like, yeah, but that's fine. And what I say to them is like, look, if you swab the back of my hand, it's going to grow bacteria, but it doesn't mean I have cellulitis. So I just kind of explain it to them like that. And usually they don't badger me more when I say that. But that kind of is a real world example of, look, there's bacteria everywhere. And unless someone's symptomatic or has infection, you don't need to treat colonization. Any other chat questions?
That's it.
All right, chat. All right, team.
Yeah, it's time.
Okay, all right. All right, well, thanks you all. Appreciate it.